In recent years, the proportion of U.S. physicians who are unionized has increased. This shift has occurred alongside a trend toward health systems acquiring physician practices, making many physicians into employees of large organizations. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Kevin Schulman, a professor of medicine at the Stanford University School of Medicine. Dr. Schulman has co-authored a perspective article about consolidation in healthcare and physician unionization. Dr. Schulman, in your perspective article, you describe several prominent successful physician unionization drives that occurred over the past year. How many physicians in the United States are now part of a union, and what's the proportion of physicians who are part of unions?
The proportion of physicians that are in unions today are actually still relatively low. For us, joining a union is a relatively new concept, a really new idea. Part of the issue is that for a long time, we weren't even eligible to join unions. When physicians owned their own practices, they were employers and not employees. So I think this idea that we're now employees of large health systems is really changing the way we think about the role of unions and the potential possibility of joining one.
In fact, you say in your article that unionization is a natural consequence of hospital consolidation and the corporatization of healthcare delivery. Can you describe how the business of healthcare, including physician employment, has changed in recent years?
What we want to recognize is the tremendous transformation in the structure of healthcare delivery in the United States. If you go back to the mid 1990s, hospitals were independent entities, physicians had their own independent practice, and this idea of governance between the two was a very collaborative relationship. Between the mid 1990s and today, the structure of healthcare delivery has changed. Hospital consolidation has been a major factor across the market in the United States. And Boston Partners Healthcare started in the mid 1990s. At Duke, their consolidation in North Carolina started about the same time. Out here in California, Sutter Healthcare started in the mid 1990s. And we saw hospitals develop into very large systems with multiple different entities. Physicians generally still were independent practitioners. About 5.6% of physicians worked directly for hospitals in 2012. Another 20 some odd percent were working in other structures that might have been related to the hospital. But that dramatically shifted over the last decade, so that by 2021, 52% of us were working for hospitals and 20% of us were working in other kinds of group structures.
So, what have those changes meant for individual physicians and for their patients? And why might those changes prompt some physicians to consider unionizing?
Underlying this consolidation was a strategy, and the strategy was for hospitals to be more effective in negotiations with large insurers over prices, the prices for services. And we've seen those prices increase pretty dramatically. So that strategy has been incredibly successful. Acquiring physician practices helped that strategy. It helped the hospital negotiate for higher rates for commercially insured patients from private health insurers. But the issue is that was the strategy. The strategy was not necessarily at a healthcare system to deliver a higher quality care, to be more effective in terms of clinical services. The healthcare delivery strategy really has been second order to all of this. And so physicians are now working in very large organizations, potentially multi-hospital systems, and are facing challenges in their clinical practice. They may not have the nurses they need. They might be short-staffed after the pandemic, and they're struggling to figure out who to work with to try and resolve all these issues. And again, 10 years ago, they owned their own practice and could do something directly to address these things. Now they're employees of very, very large organizations, and we're realizing very quickly we don't have a lot of leverage in negotiations, and frankly, we don't have management skills to work in billion-dollar companies.
You say in your article that unions could offer physicians two opportunities to negotiate over wages and to voice concerns about and influence the kinds of things you're talking about, organizational governance. Could you explain the potential role of unions in those areas?
So the first is unions are new to us as physician organization. And really what they are is an opportunity for us to bargain collectively with management. And so we all have to negotiate for our employment contracts. We might have to negotiate with our division chief. A union says rather than negotiate individually, we're going to negotiate collectively. Under the law, unions are allowed to negotiate for wages, but they're also allowed to negotiate for other conditions of employment. And a lot of the issues that we're facing on the clinical side in terms of workflows, staffing, could easily be seen as these other conditions of employment. So a lot of times when you've seen physician unionize, they're generally not arguing about wages. They're generally arguing about other clinical services, access, and staffing issues.
Is there evidence that unions have successfully helped physicians to address some of those issues?
I think we're at the beginning of this movement towards some new organizational form for physicians as employees of these large organizations. The story is still yet to be told about whether this structure can help us kind of achieve these goals and restore some role of physicians to governance and restore some professional autonomy. In the article, we say unions are not panaceas. There's a lot that's not known. There's not a lot of case history of physicians and unions since this had been so rare until a decade ago. But it's really important to understand what the motivators were in terms of a lot of these governance issues, in terms of a lot of limitations of employment and isolated physician employment contracts. And if this is not a structure to solve those problems, then we need to really think hard about how to address those issues that are so real to so many of us.
And then a question that I perhaps should have asked earlier, what are the challenges associated with forming a union and negotiating with management?
So all of us have to recognize that as employees, we're negotiating. We have a contract. It might be 1 year, it might be 3 years. Oftentimes that contract's offered to us as a standard contract, but it's not standard and it's subject to negotiation. We just don't know that. We don't have a lot of leverage in that negotiation. We don't have a lot of expertise. So forming a union is going back to the National Labor Relations Act of the 1930s. So we have to actually petition to form a union. More importantly, we have to determine something called a bargaining unit. Who's involved in the union? And in the article, we talk about several different unions that have come up in the marketplace. One is just hospital medicine physicians. One was actually all primary care providers that were physicians, physician assistants, nurse practitioners. One was anesthesiologists. So determining who your bargaining unit is an important first step to forming the union. Once you get a vote where everyone's agreed to join a union, then you enter into negotiations with management. Just because you have a union doesn't mean that management has to agree to your terms, but they do have to negotiate in good faith. And so you have protections, especially when we're raising issues with management about some of their choices. You have issues under a union structure, protections under a union structure you wouldn't otherwise have. At the end of the day, the biggest challenge for us as physicians is going to be this issue of bargaining units. A union is not a group practice. And so if every specialty at the hospital forms a union, we're all going to be at cross purposes with each other. And in terms of these governance issues, it's going to be hard to see how that's going to move those governance challenges forward. So there's some really critical issues of, are the orthopedic surgeons and the anesthesiologist and in the hospital medicine faculty or clinicians all going to work together? So even if we have collective bargaining, conflicts between different specialty areas are still going to remain.
Finally, you say that hospital consolidation trends have implications for professional satisfaction and clinical autonomy that probably aren't going to go away. So besides unionization, what approaches do you see as offering opportunities to redress the potential harms that come with consolidation?
I'd love to reflect on a talk Atul Gawande gave about 10 years ago. They're talking about 6 high-performing healthcare systems. And one of the questions was, aren't you depressed that there's only 6? And everyone was always pointing to the same 6. And he said, no, the idea that there's 6 out there means management is not constrained. They can make different choices. And so these governance issues are real. Management could address them without having us form unions by creating real structures for clinical governance at health system levels, really kind of articulating clinical plans and clinical strategies. How are we going to take care of the population that we're serving? Defining which population we're serving. If we're overflowing at the seams, who do we prioritize? How do we take care of folk? So there's a big piece of the clinical strategy, not how to be most effective in the market, but who are we going to take care of? How are we going to do the best job taking care of that population that needs to be articulated by each of these healthcare systems? And I think that's really lacking. So even without a union, we could advocate for those kinds of issues. It's just up to management to decide whether or not they want to engage with us.
Thank you, Dr. Schulman.